Of course, I get lots of questions about CBD products, but thanks to all those claims being made, people are terribly confused, and it's difficult to answer some of these questions with certainty. The clinical science is not quite there yet, but certainly the anecdotes are coming in, and I've connected with an Oregon-based company that is all about high-quality ingredients and manufacturing standards, not hype. Previously, they were called Select CBD, but they've just relaunched their brand as Social CBD. Social CBD focuses on broad-spectrum oil, something else you might have heard about, but maybe equally confused. So let's start with that. Hemp has over 60 non-psychoactive cannabinoids, and CBD is just one of them. Broad-spectrum oil goes beyond CBD isolate, contains additional active compounds that can work with the CBD to create what is known as the entourage effect. This can more effectively deliver some of the calming or relaxing effects that many people are looking for or experiencing. Social CBD's broad-spectrum oils contain zero CBD, so there's no rewarding effect. They're available as great-tasting tinctures in great flavors like vanilla mint, pomegranate tea, Meyer lemon. Simply drop it under your tongue for maximum effect. Social CBD products are in a range of formulations, each of which is clearly described, so you can make an informed decision without all the promises that sound too good to be true. To learn more, go to drdrew.com/socialcbd. That is our site. drdrew.com/SOCIALCBD, and for a limited time, you can save 20% at checkout with the code Dr. Drew, DRDREW. So it's drdrew.com/socialcbd, and then Dr. Drew at checkout. Opiates, opioids, and the problems they cause are in the headlines daily, but this drug's use actually started thousands of years ago. In this installment, we wrap up the opium series by looking at use prevention and the government's response to the opium crisis with excerpts from interviews with Dr. John Kelly, addiction specialist Shelly Sprague, author David Sheff, and Dr. Bertha Madras. And now drdrew.com presents The History of Opium. Treating patients with opioid or alcohol use disorder is a specialized area of medicine. It's not understood by all. Sometimes the lack of standardized treatment and training has kept a treatment outside the realm of medicine. Attempts to help addicts are undoubtedly well-intentioned, but despite lofty goals, patients often continue the downward spiral, even under the best medical supervision. It's critical to effectively treat withdrawal symptoms. Alcohol withdrawal may require the use of drugs like benzodiazepines for a short period of time, but once the alcohol detox is completed, patients can be started on one of 3 medications approved by the FDA in conjunction with behavioral counseling to prevent relapse. Patients impacted by opiates can be detoxed and are maintained on FDA-approved opioids like methadone, buprenorphine, Suboxone. Shelly Sprague.
The importance of proper detox is going to make or break someone's ability to actually benefit from treatment. If you have a person who is not detoxed, benefiting from treatment is going to be nearly impossible. The problems that we're seeing is the length of care being authorized to actually properly detox an individual. I mean, I'm feeling like a proper detox takes no less than 7 days. No less than 7 days, sometimes 10. 14 would not be out of line.
But the present opioid epidemic has taken a frightening turn for the worse, with increasing quantities of heroin and an even more powerful opioid called fentanyl. This is unprecedented, and we have no experience dealing with this. The preferred mode of treatment in this country has been residential and or inpatient treatment programs. Of course, many addicts also end up in prison. There's a misconception that somehow staying in treatment for a few weeks will magically cure your addiction. Forced abstinence is also called conditioned abstinence, and it places the patient at high risk for relapsing and then overdosing because they're no longer tolerant to their substance. Treatment centers need to develop strategies, of course, to prevent relapses. We've discussed methadone and Suboxone at length in the series. There are many promoting its use. There are some who decry it. Those who support argue that harm reduction saves lives and really the only way to reliably do so. Opponents point out that using opiates to treat opioid use disorder is the same thing we did in the past and creating more dependent individual and kicking the can down the road. Now, there's another option that is often overlooked in preventing relapse, particularly for patients returning home from residential treatment or incarceration. Naltrexone was synthesized in 1965 and developed as a non-opioid medication to protect detoxed heroin addicts from relapsing when they return home from residential treatment or incarceration. It belongs to a different class called opioid antagonist. It blocks the drug, like Narcan. It's the same, essentially. It works by binding to the opiate receptor on the brain cells and blocking their effects. If the person then takes the drug, they have no effect. Naltrexone use as a medication-assisted therapy is appealing because it is a prescription that has limited side effect. Another attractive feature is that it cannot be diverted or used incorrectly. Dr. John Kelly.
Naltrexone also, which is an antagonist, not an agonist, of course, but has also been shown to be efficacious also, particularly when people are already stabilized off of opioids. So if you can actually, and they just did a big trial which was published in JAMA, I think it was just about a month or two ago, which found that it was a head-to-head trial of buprenorphine, naloxone, and naltrexone. And overall, the buprenorphine, the Suboxone, did better overall. But here was an important nuance to their finding, was that if people were actually detoxed and stabilized off of opioids, they did better on naltrexone. So both of these, all three of those medications, both methadone, full agonist, partial agonist buprenorphine, and an antagonist, naltrexone, or the injectable Vivitrol, once a month shot, was shown to be very helpful for people with opioid use disorder. So these, of course, are scalable in the sense that they can be quickly implemented, disseminated and implemented, as long as docs are trained to, as you say, to know what to do, and use the proper protocol to deliver the treatment.
People who are interested in using naltrexone to overcome addiction are often highly motivated. Now, if the pill is not taken as directed, the cravings and the effect of the drug can rebound. Now, there are implantable formulations out there to give you under-the-skin continuous dosing of naltrexone to prevent the possibility of not using and then going to use your drug. It was approved by the FDA for the treatment of opioid addiction in 1984 and for the treatment of alcoholism in 1994. It's available as a pill or a monthly injection also, called Vivitrol. People like it because they know that they're protected. They don't have to worry about taking a pill every day. It's not a cure, but it can help facilitate a structure and a possibility of sustaining abstinence through difficult times. Now, before starting on naltrexone, people, of course, must be detoxed, because if you suddenly block the receptors, you can bring on a more severe withdrawal syndrome. It can also negatively affect the liver, so careful monitoring is crucial. Self-help groups have traditionally been concerned about medication-assisted therapies because often they are drugs that are psychoactive. This has no psychoactive activity. Shelly Sprague?
I think that if you understand the stages of addiction and recovery, there is a place for harm reduction, and it is pre-contemplative to get sober. If you're going to keep kids alive long enough to reach their 20th birthday, you might need to go with the harm reduction model, because they're not significantly schooled in the availability of resources. They're too young to, I guess, go into a resourced place, going into rehab. Their mind just isn't there yet. It's just not ready yet to be able to take on some of the concepts of abstinence-based. And I think if you're going to save people's lives, you may have to do that initially. But I think post-25, if people are still contemplative, there's an underlying issue that needs to be addressed, and it's not using drugs.
Naltrexone and other medication-assisted therapies cannot replace recovery programs and other treatments, but should be considered in many cases. The question, though, still remains, how do we select the right treatment for the right patient? Who should get methadone? Who should get Suboxone? Who should get naltrexone? Who should get neither? There isn't a one-size-fits-all, so make sure you have a very skilled clinician who is able to answer that question. What is the right medication-assisted treatment for me? In 2016, over 11 million Americans misused prescription opiates. 1 million used heroin. The growing black market is also a major driver of increased deaths due to fentanyl. The opioid epidemic is socially, medically, and economically overwhelming. Not only does it affect people who are in the throes of addiction, it inflicts terrible and often irreversible emotional, physical, and financial damages on families, friends, communities, social services, law enforcement. It's a relational disorder. It affects everyone. Needless to say, governmental intervention, cooperation, and leadership is vital when it comes to making any headway. We have to commit to solving it. David Sheff?
Well, we wouldn't be in this bad a shape if our government was on this in the way that should be. There's a lot of things that need to be done. Some of them are being done slowly now, only after and because of the current epidemic, because of the crisis. We're losing so many people, so many of our kids. Part of it is money. We need more money for prevention, and we need more money for treatment. People need access to treatment that don't have it. Only about 1 in 10 people get any treatment whatsoever, and of those who do, treatment is often mediocre at best. Sometimes it's actually destructive. We need more access to general health care, mental health care, because they're all mixed up together. People who don't have health care are much more likely to have drug problems, much more likely to become addicted. The access to some of the medications that can save lives, like Narcan. Surprisingly, here's a medication that can reverse an opioid overdose and save someone's life. And yet, in some communities, it's not available, and in some places, there are even restrictions to it. There are even sort of these moralistic views around it that suggest that if somebody can be revived from a drug overdose, they're more likely to use drugs and overdose, which is nuts, because we also know that people aren't. That's not why people are using it. It's not because they're afraid of dying. They're using for other reasons.
Some of the agencies that are currently working to get this crisis under control: Substance Abuse and Mental Health Services Administration, SAMHSA, a lot of great stuff on their website. Centers for Disease Control, who are setting very rational guidelines. National Institute of Health, the Food and Drug Administration, who are trying to come up with new biological means of treating this disorder. And riding herd over this is the White House. In October 2017, the president declared a 90-day public health emergency, promised to roll out a tough advertising program intended to spread awareness about the problem. His plan aims to galvanize the government to end the crisis. The website crisisnextdoor.gov was launched. In October 2017, Dr. Francis Collins, director of National Institute of Health, appeared before the Senate Committee on Health, Education, Labor, and Pensions to outline how the agency plans to do this. 1. Access better prevention, treatment, and recovery services. The Department of Health and Human Services issued over $800 million in grants to support a variety of efforts. For example, the Health Resource and Service Administration allocated over $4 million to grants to 34 rural health organizations to increase access to treatment and recovery in those communities. Number 2, compile and report better data pertaining to the epidemic. CDC released the first annual surveillance report of drug-related risks and outcomes. Number 3, develop more effective pain management strategies. This is, of course, an effort to promote healthy, evidence-based approaches to deal with pain, especially chronic pain, which, as we have described, does not improve with opioids. Number 4, improve availability of overdose-reversing medication. In April of this year, the Surgeon General released an advisory on naloxone and opioid overdose, which promotes the importance of access to the life-saving drug. I carry it with me as much as I can. Number 5, improve research about pain and addiction. This effort spearheads the development of cutting-edge research on pain and addiction. In September 2017, several agencies, including Department of Defense, NIH, and the Veterans Affairs, have announced a partnership tasked with developing non-drug treatments to address pain management needs of veterans and members of the military. In March of 2018, the President signed a $1.3 trillion budget, which included $4.2 billion allocated to fight the opioid crisis. It's a large amount, but it's noted that the fallout from the crisis across the country is probably more like $500 billion annually. The President's Commission on Drug Addiction and the Opioid Crisis was established to cut down on bureaucracy, increase awareness about drug misuse, reduce inappropriate prescribing, improve drug monitoring programs, strengthen law enforcement efforts, reduce the amount of illegal drugs entering the country, and expand access to treatment and recovery services, as well as provide overdose-reversing drugs, as well as development of opioid alternatives to address pain. Progress and headway is really underway in all of these fronts presently. In July 12, 2018, Attorney General Jeff Sessions announced the formulation of Operation Synthetic Opioid Surge. This initiative intends to reduce the drug supply in areas that have been most impacted by the crisis. Part of the goal is to identify wholesale distribution networks and international domestic suppliers. They're getting on these guys, and it's improving. The current administration has held summits, released initiatives, and convened commissions designed to fight this battle. And those who are on the front lines, their efforts should be applauded. Critics, however, argue that substantial progress has yet to be made in the war against opioids. Dr. Bertha Madras?
Why do we revere this 3-pound organ sitting on top of our shoulders more than any other organ in the body? And it's because it's the repository of our humanity.
Yes.
That thing that enables us to compose poetry, to write laws, to conjure up DNA, black holes in the universe, these wondrous things that the human brain can do, and we must protect it at all costs. And one of the best and safest ways to protect it is not to introduce chemicals in it that are going to alter the circuits, the biology, the cell biology, and the genes of the brain.
I'm here to tell you, as somebody who is on the ground, it is improving. The data will reflect it soon, but we have a very long way to go. So I hope this is a helpful monogram for you. The opioid crisis is unprecedented. I saw this coming. I found old footage of myself screaming about it more than a decade ago because I was dealing with it. I could see the chronic pain patients getting strung out on these drugs. I could see the overprescribing. I was scared to prescribe the pain medication because if a patient came in with pain, the legal system set up an adversarial relationship where every pain patient could potentially be a crime if you don't adequately treat it. So doctors referred all their pain patients to pain management, and pain management took the position that pain is whatever the patient says it is, and it was off to the races. It's stunning to me that my peers and the physicians of this latter half of the 20th century did not seem to know the history of the latter half of the 19th century, where we had a similar epidemic, and we did the same thing. We started trying to use addictive drugs to treat addictive drugs. So I'm always suspicious and concerned when we do that, though it does appear that medication-assisted treatment with methadone can save lives, with Suboxone can save lives. My grave fear, though, is that people get strung out on these drugs and we're just kicking the can down the road. People's underlying psychiatric disturbances, trauma issues must be managed, and they have to learn to live drug-free. So we cannot tolerate people using other substances while they are on these replacement therapies, and many times that's not even tested for. So there's many things still to be dealt with and many concerns that I have. One of the great advances that is moving forward is the evidence basis for mutual aid society. 12-step and other mutual aids are available everywhere. They're ubiquitous, and they will come and get you. And there just simply aren't enough professionals on earth to provide the kinds of services that addicts need. And people who have themselves been the object of that service by their recovering peers want to give back and actually find that they stay sober by doing so. So they are readily available to help people and support them through the most challenging times of their early recovery. Later, the disease of addiction really has associated with it difficulty with emotional regulation. And emotional regulation is something that is built in an interpersonal context, meaning in closeness with other people. And in fact, the 12-step experience, the 12-step is really merely a guided relationship in an intimate context where you learn how to give up control, and you give up control to something, some sense that there's something bigger than yourself. Then you sit in a close proximity with another person, you tell them all the things you're ashamed and guilty about, and you share it with them, and they reflect back to you their own experiences and how they're experiencing yours. It is a deeply emotional experience. It is critically important. Other things like cognitive behavioral therapy, emotionally focused therapy, trauma therapies all become extremely important in a full recovery. After all, what we are hoping for our patients is return to a flourishing life, not to be handicapped by the fact that addiction was triggered, not to be troubled and preoccupied on a daily basis, but to be free and flourishing and able to be of service to their peers who may be struggling with a similar condition. We've got to remember that addiction is a disease of the brain where the parts of the brain that really usually are dedicated to survival become hijacked, such that the brain wants to do things it doesn't like anymore and aren't working anymore, yet it pushes the individual to keep repeating these things and using these drugs. In addition, whatever compelled them to experiment with drugs in the first place, the problem they were trying to solve, that problem needs to be managed as well usually in a professional setting, though to some extent the 12 steps itself can go a long way to healing much of this stuff. I want to thank my guests, Dr. John Kelly, Dr. David Sheff, Shelly Sprague, and Dr. Bertha Madras, as well as all of you listeners as we explored the history of opium. I want to thank Michelle Poe and the staff of DrDrew.com for helping pull this together. You can read it in its entirety at DrDrew.com and keep an eye out there for other future series coming your way.